Good morning, everyone. It's 9 o'clock on Wednesday, June the 2nd, and this is our second benefits committee for 2021. Everyone should have an agenda. We're going to talk about some new coaching programs, the claims experience review. We're going to talk about renewal projections, 2021 rate discussion, and we're going to discuss when we'll have our final meeting, which will probably be sometime in July, and then we'll have some time for questions. So I'm going to hand it over to Sean Fleming from the Gehring Group to initiate the meeting.
Thank you. I'm just checking. Can they hear Karen? Okay, she said it's good now. She thought it was muted, so they can hear us now. Well, good morning, everybody. Started off, gave you an agenda. We have claims experience in front of you, but we actually wanted to talk about something that there's no handout for first. And I'll kind of leave this off, and Jennifer, Jill, Tony, whoever wants to jump in with anything there. On the coaching program, as you all know, we have the clinic. We have a health coach in the clinic, and that health coach, just so everybody knows, is the health coach and the wellness coordinator are ultimately funded out of the premiums that are being paid to Cigna to administer the program. Part of that administrative fee is they make those employees their employees, which everybody in the clinic obviously is ultimately a Cigna employee. But as an example, the doctor in the clinic, that's part of the city's bill where they pay for staff for that. But the wellness coordinator and the health coach right now are ultimately paid for kind of by Cigna Medical, let's call it that, instead of the Cigna clinic, which ultimately the city just pays for. So we've been monitoring, if you all remember, we put the health coach in 2019. What happened was we had an on-site kind of claims as a helper, if you want to call it that, for Cigna, help the employees with finding a doctor, things like that. And we had noticed at the time that people where they, used to maybe have 50, 60, 70 people asking that person for help a week, went down to like 5, 6, 7 a week. So it was kind of a waste of money. So we rolled out the coaching position. And we've been monitoring the effectiveness of that coaching position since it put in. It started off okay, lower than, kind of in line with where we expected, but we thought that it would grow. More people would engage with that coach. And it's grown a little bit, but prior to COVID, it really hadn't grown at the rate that we expected. And since COVID, a lot of things have changed, right? People are interacting with different mediums. So as we've been looking at that, the concern has started to be that position has become underutilized for the resources that are being allocated to it. And I'll ad-lib a little bit here. I obviously haven't been able to do the coaching because I'm not a City of Clearwater employee, but I do know that the coach is extremely well liked for the people that work with them, extremely well respected. So this has nothing to do with any of that. But one thing that we've been looking at is there a better way to allocate those resources? And one option that has come up that we wanted to talk with the committee about and get any feedback or thoughts is we have a nurse practitioner or PA, one of the two, that has sort of been per diem. So they're getting paid just an hourly rate. They're not actually a Cigna employee. And that individual obviously can see patients, can take care of preventative care, chronic care, sick care, ultimately provide more access. And the clinic would really like to have that individual as a salaried employee, so they're always available. We don't lose them. So one thing that we've been working on with Cigna is looking at if we were to eliminate that coach position, Cigna Medical would ultimately be able to fund that other provider in the clinic. So the city gets more access to care, kind of at no additional cost, probably actually a little bit of a savings. Nothing that is going to, make a 30% difference because there's some difference. But I think the biggest difference is you get more access to care with a provider that people like. and I just blanked on the name. Is that
Yolanda.
Yolanda? I'm sorry, I wanted to say.
That's okay.
So Yolanda is the individual that's kind of filling that position. So what we wanted to talk about with the committee, I'll let, if anybody wants to add anything to that, is we're looking at possibly eliminating that coach position and to be able to use that to have more access to care time, essentially.
Would this be a full-time position at the clinic, or would this just be
It's
partially?
about 30 hours.
Yeah, it's about 30 hours, but with the potential of it being more when like the doctors go on vacation, you know, and stuff like that. That's what we use her for now. Is because the, you know, so Dr. Tarancinko and Molly right now both work 410s. And so Yolanda fills in, you know, on that, you know, Monday and or Friday, so that there's always two providers there. But in addition, you know, when they take time off, she fills in on that, but it's inconsistent. And so this is a way to make that more of a consistent, that she's ours and she'll provide these many hours for us. So it does provide more access. But so no, to answer your question, not on a full-time basis. And yes, the health coach is full-time. And that's why he said it's not a dollar for dollar. There's a little bit of a savings, not that much savings, because Yolanda, and I don't remember if she's a PA or a nurse practitioner either, but that rate is much higher than what the health coach's rate is. So you know, so there's still a little bit of savings. It's not full time, but not a significant savings because her rate is higher anyways because of it, you know, the different position.
Sure.
But you know, so just to piggyback of what Sean said, the people that use Nyla love her. I've never gotten a complaint, you know what I mean, or anything like that. It's just that it's not utilized. And she's tried, you know, we've tried in terms of different marketing things and whatnot. It just doesn't seem to be something that our employees are, as a whole, are interested in.
And as in the fire department aspect, I have not heard much utilization at all on the fire department side using the health coach from the clinic. In fact, I've heard nothing on the fire department side of using the health coach at the clinic. Maybe because we have our own peer fitness instructors.
Sure, yeah, and it's just, like I said, it's just not, it doesn't seem to be a benefit that there's a lot of interest in. So we're trying to think of, so should we reallocate that, you know, rather than continue to spend the resources on having a full-time position that is not being utilized. Although, like I said, making an impact, I don't want to take it away, you know, from the impact that she has made with some people. So that's why we're proposing this, and also wanted to kind of similarly, or at the same time, just remind that we do have this Food Smart program that has a dietitian built into it. So I've done both. I have worked with Nyla because I like to know what we're offering to our employees so I can speak intelligently on it. And then I've also utilized because it's an app, it's a multi-source thing, it's an app that has all kinds of recipes and we'll just kind of help you build a food plan and it'll do your grocery shopping and everything for you as well. But in addition to that, they have a dietitian that is at no charge. It's virtual, but it's, you know what I mean, it's kind of like a telehealth type of a thing. And, you know, for me, it wasn't a decline by not having the person physically there. I think through COVID, we've all gotten used to doing so many things remotely. That the service will still be provided to our employees. And that's what I think is, I want people to understand, not in person though. Now, you do have the option through the health insurance to go to a dietitian in person, so that still exists as well. But through the Food Smart app, there is no cost to the employee to do that.
Gotcha.
And then additionally, we're also thinking about.
Yeah, so there's another program called Amada that we're looking to roll out. We'll bring some, you know, maybe probably a video is probably better. They have some stuff, but Amada is a program. They're an independent company from Cigna, but Cigna has done a lot with them, as of some of the other carriers. We have United Healthcare clients with Amada, Blue Cross clients with Amada, and clients. They started off as a diabetes prevention program. So essentially the criteria to engage in the Amada program was, I think you had to have like 2 risk factors. There's kind of a list. If your BMI is over 25, if you have high cholesterol, high blood pressure, high blood sugar, there's a number of different things you ultimately qualify, but some people won't. But that's not really the audience we're trying to get after anyway. And the way Omada works, what's kind of interesting is when you engage in Omada, they send you a digital scale that actually has a cellular signal in it. And it goes to your health coach at Omada that you're engaged with. And, you use that scale, weigh in. There's different things. There's if you're pre-diabetic, and diabetic nowadays on the planet is probably 15 to 20 grand a year. So if we can keep somebody from getting into that state, it's obviously a worthwhile venture. Diabetes is probably, if you count cancer aside, cancer is largely uncontrollable. Cancer is more about, can we detect it early enough to reduce the cost? Diabetes, we know we have a lot of people in that pre-diabetic state. Voluntary program, all that data is sent to the health coach. You can engage with them on the app, via video calls, text. They'll actually do nutrition as well. That's a big part of it. You can log your food.
Is there a cost to employees from that?
No cost to the employees. And what's kind of cool about the program is, we get bombarded in our office with people trying to sell us programs, right? Oh, $5 per employee per month, and we'll do this program for you. And what happens is you pay all this money and then 7 people do it, and you just wasted a bunch of money. So the way Omada works is there's a one-time charge that hits as a preventative claim. So it's free for the employee and it'll hit the claims experience. That covers the scale, the packet that comes, all that. And then Omada their deal with Cigna is they're only paid if you actually lose weight. So if somebody does the program but doesn't really engage, they sign up and then they just don't do it and they don't lose any weight, or they just disengage in the program, there's no charge. So it's basically, I think roughly in the first year, it's $13 for every percentage of weight loss.
So it's more of a weight loss program as opposed to more of a dietitian type of program?
No, it actually is, I would say, more of a dietitian and an overall kind of management. They're using the weight loss as kind of the benchmark, because you're not going to go every 2 weeks and get your blood sugar tested for them to say, oh, we lowered Sean's blood sugar 2%. So the weight loss is kind of the metric they're using, but it's more about improving that overall kind of metabolic health, because that's ultimately what puts somebody in that pre-diabetic.
Because there's still a lot of people that are fighting with their A1Cs around 6s and 7s that are not at a lower weight or a higher weight that could benefit from this program, but if their weight is not too high, would they be excluded from this program? That's the question.
No, so what's kind of interesting in Cigna's, so Omada's been growing quite a bit. Omada started purely as a diabetes prevention program. So if you're already diabetic, that program wasn't really designed for you. That's a whole nother monitoring, all those things. They actually, in the meantime, and I think Cigna is working on terms on how you can add these programs as well. They've created a type 2 diabetic program that would potentially be an option down the road that's meant to target the people that are already there. And part of that program, when they roll it out, is going to be like, it would include your monitoring equipment. It would have that digital glucometer. So I would say that's kind of phase 2. The one we're looking at initially would be just looking at that pre-diabetic, not the people that are already on those medicines. We're trying to get that percentage of people from getting there, but then also potentially rolling out that down the road for people that are already there. And I believe with that program, they're probably going to have a hypertension component of it as well for the people that are already there, because there's such a correlation between hypertension and diabetes that I think in that program they're also going to have like the connected blood pressure monitor, so that coach is seeing all that data.
And then in correlation with that, we still have the dietitian that can go that we have in the city that can go ahead towards the people that are in type 2 diabetes or type 4 or type 1 diabetes and work in their food stuff as well. So it sounds like a good program.
Yeah,
especially if there's no cost to
Oh
employees.
yeah, like I said, I love the sound of the Omada. I have no experience working with it, but the way that it sounds, it sounds like a win. And again, so we acknowledge in terms of shifting this, the services that people, in terms of if we decide to not have the health coach anymore, and that's why we're trying to have these replacement programs so that our employees understand that it's. In all honesty, the weight and obesity is one of our highest cost drivers because it
Oh, yeah.
leads into everything else. So it's not a matter of saying that that's not important, it's just not utilized. So how do we, you know, how do we engage in a different way with those services without having that? And so this is what, you know, our thought process is.
And the biggest complaint I've heard about the healthcare clinic is access. So this will be an increase in the access by doing that, which would be a positive. So, yeah, I think we, as far as IFF portion of it, would be very pro to having an additional clinician, PA, or ARNT over there as opposed to the health coach.
Yeah, my understanding is Yolanda gets very positive feedback
Yeah.
from everyone, and candidly, the clinic, in some regards, you know, we've been dealing with this for a couple of years, because that person's in that kind of per diem status, they've been afraid that one day she's gonna get another job or walk for that, and this kind of helps, you know, lock in that we do have a provider that people like.
And this is coming out of our 80,000 a month-ish that we're paying Cigna to manage it, or is this coming out of our?
Yeah, I mean,
Our
ultimately, they're funding some of those in that. So yeah, so overall, it's kind of cost neutral. It's just moving it from one to the other. So we wanted to start with that. At the next meeting, we'll bring some more information on the Amada. So you guys can kind of see it. We just wanted to have this discussion. I'll just say, you know, discussion has largely only been in this room. So nobody at the clinic knows that we're having this discussion. So obviously just kind of keep things on the confidential side there so no one finds out the wrong way. So it's definitely not an easy decision, something we play with a lot. You know, unfortunately, when you look at the numbers, it's you know, sometimes probably averaging 3 people a day, and maybe, you know, it's just, you can't have a full-time person seeing 3 people. You know, they need to be seeing probably 8 or 9 or 10 a day to really kind of justify that position. And I think a lot has changed with COVID. You know, people are much more comfortable with virtual than they were a year and a half ago. So I think that opens up some opportunities, and we have to keep evolving sort of with that.
Can we, along the same lines, send out another email before July, stressing again that we have a dietitian and such that are kind of separate than the clinic that they can access?
You know, so, and we've already done that, you know, in those wellness emails, and I know they come out every week and there's a lot of stuff in there, but, you know, we are actually having one of the Wellness Wednesdays. We're, you know, having food smart people there to like talk about it, you know, and things like that. So we are certainly trying to promote the program.
It's today at 11, actually.
Okay, so today, I was saying it was one of the Wednesdays, that, you know, to talk about the program and stuff like that. And we'll continue to do that, but to answer your question, yes, we are doing that.
Yeah, I was gonna say, help give more promotion to this one and less to the healthcare clinic, so that way it makes the transition smoother.
Yeah. We are, we're pushing it, and like I said, I will tell you, like, I'm a huge fan of the Food Smart app. It's amazing.
Cool.
Yeah. Okay. Any other questions from any of our remote people that have in regards to this item?
Gina just mentioned that this is being recorded, this
Yeah.
meeting, so
Yeah.
in regards of posting it, to try to confidential, maybe we wait on posting it.
Good point, thank you, Gina.
Perfect.
Okay.
Good. So in July, when we set a date for that, we'll bring back some of the Amada stuff. I think you guys will like it. It's not necessarily for everybody, and it's not meant to be, but just meant to give more options. So, and I'll just say on that, we're also going to look at kind of with some of those programs, if there's any way to integrate them more into the motivating incentives as well. So there may be a way that we can tie some of those together and actually make it, you know, qualify as one of the incentives so people engage in it. All right, you guys ready to hop into claims experience?
Oh, yeah.
Yes.
We
think.
Yeah. So everybody has in front of them the claims. I think everybody's been here before. And just, I guess the people online probably can't see it. I was just trying to think if there's anything Cam could do, but I don't know if there is. So, okay, we'll dive in, and for everybody online, we'll send this out to you electronically right after. So everybody wants to take a look. You guys are kind of pros with this, but we'll just run through if we want to look. Maybe we'll go to the gold. So far through the first 4 months of the year, we have about 6.8 million in funding in our first column that's gone into the plan. Of that, 320,000 goes to Cigna to administer the program. And then in the next column, we have about 512,000, and that goes for our reinsurance. So anybody that goes in the middle of that 250 and 300, so basically 300,000 in claims, is covered by the reinsurance. So 512,000 for that coverage. And we'll take a look at some of the statistics on that year to date. There are a couple large claims that are driving things. So then going on, taking a look at our claims, we've had 4.6 million in claims for the year, 1.5 million in pharmacy. So total claims have been about 6.2 million. If you want to go up to that reserve account column, we can kind of look at the month by month. You'll see in January, we had a very good month. We had 325,000 of surplus. And then we've had deficits the last 3 months. So the plan's running a little bit higher, and we'll talk about what's driving that in a second. But if you take a look, then we had pharmacy rebates that came in at just shy of 1.1 million. So when we put all that together in the wash, we have a surplus year to date of about 900,000. Historically, most plans, they obviously run a little bit hotter in the beginning of the year, because remember, everybody on reinsurance starts at 0. So you have a couple of catastrophic claims. The city's picking up that first 300,000. Once that individual hits 300,000, for the rest of the year, the reinsurance, Cigna in this case is so overall, not bad. We've seen a little bit higher jump in the beginning. If you flip the page real quick, pre-COVID last year, you'll almost see in the first 3 months, and then COVID hit kind of in April claims. It was very similar last year. And if we even went back a couple of more years, you would see that that's kind of the same case for the city. The first couple of months, January always seems to be low because it's largely December claims, and then it all catches up coming in from there. So overall, plan running pretty consistently. If you want to look in the bottom kind of left, you can see just the graph of those last 12 months of the claims per employee per month. And you see just that little bit higher than the average in February, March, and April, but we'll talk about what's driving that in a second. And you see there still May, a little bit on the lower end. That was kind of the tail end of things starting to reopen with COVID. So there's a little bit there where it's a little bit on the artificially low side. By the time we have another month of claims, we'll probably see that irregularity gone. We'll be looking at that. I know we talked a little bit in the last meeting about how insurance companies and actuaries are trying to account for part A, kind of what didn't happen. And then part B is there an impact of things that were delayed? So if I didn't get my mammogram for 6 months and now we found something stage 2 versus stage 1, how much more does that cost? Grappling with that. So we'll talk about that when we look at the projections. Overall, if what's a little abnormal for the city, and we'll talk about why in a second, is if you look in the box that says medical and pharmacy claims per employee per month, you see medical's up 11.3, which that's a little bit higher than most of our groups are trending right now. But what's interesting is a lot of our groups, pharmacy is up 20 to 25%. You guys are only up 5.7. So that's actually a positive there. We'll take a look. If you want to flip back though, to understand kind of what's driving, if you want to flip back 2 pages, we've got our catastrophic claims. Really what's driving that increase year to date is those catastrophic claims. So if you look at the first line, this is really when we see that higher trend, we have a claim that's almost 1.1 million. So that obviously the city pays the first 300,000, but that kind of abnormality and that spike is what's driving a lot of that higher trend. So as the year goes on and we have more mature data, the impact of that sort of shrinks in the big picture, right? But when you only have a couple of months and that all kinds of hits in that 1 month, it makes the numbers look a little bit worse. But ultimately, that's what the insurance is for. So we do have a few more of those high cost claims this early in the year. That's part of what is driving it there. Do you guys have any questions on that? I know this group is pretty much pros with this, so I don't want to, there's no reason to really drag it out and do a bunch of stuff. Behind that, we have last year is the second page. We have the high cost claims. And then to that point, if you want to look at the fourth page, we did a little look at January to April, year to year. And if you go to the, so the first line down is the total gross claims. So you'll see last year you were 5.6 million. That's a little bit immature because of COVID. Versus 7.1 this year. Last year you had 6 claims over 100,000 at that time period. This year you have 8. But look at the difference in the amount of those catastrophic claims on the next line. 861 last year versus 1.9 this year. So that extra, jump that we've seen is really those couple of claims. And obviously when you have $1 million one, that's what drives it. So you'll see overall year to date, you have about 755,000 in reinsurance paid back. Just to put that in perspective, you only paid them 512 so far. So they're losing a little money on the reinsurance this year, but they've had years where they haven't paid, and that's the way reinsurance works.
Sean, on the previous page, it looks like there's been stop loss February, March, and April. The totals, so it should total almost 2 million, it looks like, the bottom line of the previous page.
Which number are you looking at, Jeff?
Yes,
Oh, that's not the stop loss. That's the total of those claims.
that last line that says estimated stop loss.
Oh, yeah, okay, the seven.
That's because that 755,696 matches for April, but there were also amounts in February and March that don't look like they're included in that 4 months total on the next page.
Yeah, so I'll pull the high cost claim report and Cam's on, maybe Cam, if you want to
So
text
those
me
are
on
300,000 minus employee number one's cost. Employee number one cost minus 300,000 equals the stop losses.
Yep, and on,
It just looks like on that next page, that total stop loss recovery ought to be closer to 2 million.
yeah, I'll double check that, and I know Cam's listening, so I'll have him.
But that's the same thing for the total high claims cost of 1,960,000, unless that's a cumulative number in April. But it sure doesn't look like it on the previous page.
Yeah, Cam, why don't you text me that, because I know Cam put the report together. I don't know how he did the calculations, but I'll circle back and give you that answer in a second.
Actually, it looks like it is cumulative.
Yeah.
Well, no.
Yeah, and I'll verify that, Jay. No, you're talking, were you looking at the 696, Jay? Or the 755? Now I
I'm
see,
looking at the
now I see what you're
755.
talking about. So the 755 is the estimated stop loss recovery.
Yeah, but that's It indicates that's a 4-month total, and on the previous page, it's shown as a monthly total.
Oh, yeah, I see what you're saying. No, that's cumulative. We're doing that rolling.
So these aren't monthly totals, these are cumulative totals through February, cumulative total through March, and cumulative through April.
Correct, yeah, so
Okay.
claimant
That would make
one,
sense.
so what we're showing here, now I understand, that's why I was getting
Okay.
confused. I think Kim's texting me, yep. So claimant one is an example. In February, so we on this report, when they hit 100,000, we put them on this report. So claimant one in January hadn't had 100,000 in claims, so they didn't hit the report. So in February, when we got their claims, it was 964.
You're just tracking.
So in March, yeah, so what we're tracking here, so in March, they only had 3,000 more in claims.
Gotcha.
But then from March to April, they went up 88,000.
Okay.
Now I understand where you're going. Yeah. So what we're looking at here, the big reason we do this report kind of this way is we're ultimately trying to see if, as an example, if we think somebody's had the bulk of those expenses and now they're done with the majority of their treatment. As an example, if somebody has, heart surgery, they're going to have costs leading up to it, tests, all those things. Then they'll have the big hit for the surgery. But then in subsequent months, if they don't have any complications, they should only have kind of follow up with provider type claims. So what we're trying to gauge in that report is, is somebody largely done with the bulk of those expenses, or do we think it's going to be ongoing? Sorry,
These cumulatives are only based only on that particular claim, not other medical things that they would be doing.
No, it's everything. So it's ultimately everything. We can't separate it out, but that's the way the stop loss pays, right? The stop loss doesn't matter if you have a knee and a shoulder; those aren't separate. Like it's just all your.
Once they reach that $300,000, anything over that for the rest of the year,
For the
the
rest
stop
of the
loss
year.
pays for that employee.
Yeah. Sorry, Joe.
That's good to know.
I wasn't understanding what you were asking. That's why I was getting confused.
We've only had one employee that actually we've had to use the stop loss so far this year.
So if
Or
that
one
indi-
claimant, I should
Yeah,
say.
if that individual has expenses the rest of the year, it won't hit the plan. So. All right, you guys want to talk about the projections?
In the previous year, we had 2.2 million in reserve.
Yeah, the surplus from last
Surplus.
year was 2.2 million. I would say maybe, I'm guessing, but maybe 500,000 to 600,000 of that was a little bit of an artificial boost from COVID.
Okay.
But I also think that some of that has, for lack of a better term, returned to the plan in the beginning of this year.
Okay.
If, based on what we've seen kind of industry-wide, the prevailing kind of thought is that most things that have come back into the plan probably have by now. Nobody knows 100% for sure. Groups that were renewing, we had a couple groups that renewed in the first quarter, as an example, April, so they're using data maybe last calendar year. Those entities, it's definitely much more of a guessing game. Like, is everything already back in the data, or is it still out there, so to speak? And if you're fully insured right now, it's fully insured renewals. I think everybody's at the mercy of the insurance company saying, "Oh, we think we need to add 5% because of COVID," whether they have any numbers to back it up or not. So fully insured, there's a lot more fights going on right now. So I'm gonna walk through this a little bit on the brisker side, but so you guys stop me with any questions, because there's just a couple points I really want to talk about with it. I know you've all looked at the bottom line already. So overall, the projections come out to a 5.3% increase, but I do want to walk through it just kind of quickly so you guys understand a couple things and even talk about an initial projection we shared with HR 2 months ago. I want to talk about some of the differences because of COVID, just so everybody has a comfortable understanding as to what's going on in it. So on the top line, and let's look at the total column, we broke out medical and pharmacy, and explain why in a second. So total gross paid claims over the time period of May 2020 to April 2021 was 19 million. The first thing we do out of that is in that time period, we back out any catastrophic claims. So any claims that are over that $300,000. So the Cigna reporting through the time period when we got it, I think there was a little bit of extra claims that came in on that one claim, but it was 991,000 because obviously they're a little bit over $1 million this year. With those large claims, sometimes in the way they come in, the data moves. So we did this projection before we had gotten some of that. So there's a little bit of a variance there. Actually, no, there's not. I'm looking at the wrong one, I can't read. The first line is we take out capitation, which are the fixed costs paid to Cigna. So the capitation is going to be certain lab work, imaging, mental health is capitated with Cigna. So we pull out 991,000, and then we pull out any individuals that have reinsurance, that would apply to reinsurance. So we have one claim kind of in that 250 to 350 range over the prior 12 months. And we had 3 that actually exceeded 350 looking at the prior 12 months. That's not going to match up to that page you had because that's only plan year. This is the last 12 months. So we pull out right away 2.3 million in claims. That nets us 15.7 million in claims. So the next line is the one I really wanted to talk about. So maturation factor. So this is where everybody is, quote unquote, fluffing their projection for COVID. And what they're trying to look at are those things we talked about earlier. How much should have been in the claims that wasn't because people didn't go to the doctor, and then is there an impact to, is there an impact of people delaying that care? What does that have? So when we looked at this projection 2 months ago, when we had April and May, which were really low, there was about 5% in here that we have had in kind of for COVID, right? If you take a look now, because we still have that month of April, we think more has come back. We lowered it down, the actuaries looked at it to 1.5%. Interestingly enough, the projection still ultimately came out pretty much in the same range because as claims came back in, we reduced that COVID impact, so they essentially washed each other. So if we looked at this again next month, with another month of claims, this will be down to 0, but we'll obviously have that month of claims probably wash out in a pretty similar region as well. So going down, that gives us our total paid claims, 15.9 million. We divide that by the average on the plan, multiply it by the current number in force on the plan. So that brings us 15.8 million in projected claims. So the next line is our trend, our medical inflation. So the actuary looking at, they use a Siegel trend survey, which looks at medical care by region. In the area, we're actually at about 5.5% medical inflation for medical. Pharmacy, about 12.5%. The good news on that is those aren't dollar for dollar, right? They're not weighted 1-to-1 because there's a lot less in pharmacy claims than medical. So when we take those and we project that out, we compound that over the 20 months, basically that adds 13% to the projection to account for increased costs of medical care. And if you want to go down a couple lines, we didn't make any plan changes. So then what we do, where you see that 1.2 million number, is we put back in that first, the city's responsibility on those catastrophic claims. Those don't get trended for medical inflation. And then we add back in the capitation so that that's not trended as well, because that's not going up 13% per year. That's marginally going up, if at all. We subtract out the pharmacy rebates, then going down, we add the administration, the reinsurance, PCORI fees, that's the PPACA. What that embark is, so everybody knows, I don't know if we talked about it, but right now there's 2 gene therapies out there. So it's really not a drug, it's more medical care, but ultimately kind of works through an infusion. There's one that cures spinal atrophy in children. There's another one that cures a progressive blindness. They cost anywhere between 1.1 and 1.4 million. But in most everyone, they cure these things, which is amazing. I mean, spinal atrophy is something in a baby. But obviously that could be a $1.1 million expense to the plan with your reinsurance. So what Cigna started is something called Embark, which is basically you pay 99 cents per member per month. And if you ever have one of those claims, it's just covered by that. So it's almost a second form of reinsurance to cover those gene therapies. The one that will be interesting that was delayed last year during COVID is there's one coming out that's supposed to cure hemophilia. And hemophilia, if anyone knows, it can easily be 600,000 to 700,000 a year in medications alone before anything happens. We have a group where there's an individual 600,000 a year, but if they so much as cut their leg, it can easily be a 2-month hospital stay to control the bleeding. So if this comes out and cures hemophilia, it'd be amazing. But it could have a $1.5, $1.6 million price tag with it. So this Embark program covers that.
Embark basically covers any of these gene therapies that come out, not specific ones, but any of these gene therapies that.
Yeah. And what I think will happen, although they haven't done it yet because there's only 2 out there, is I think insurance companies are going to say, okay, here's the deal. Like, either buy a program like Embark, or we're going to exclude those from stop loss. Right? They're going to say, well, you can still cover it, but we're not giving you that $300,000 limit.
It's all experimental, and then we'll cover it.
Or something. They're going to say buy one of the 2, but we're not giving you the bet. You guys have a pretty high level, but still, if it's a $1.5 million claim, they're picking up $1.2 million with that reinsurance. So that's why the Embark, they haven't said that yet, but I think you'll see that that's going to be your choice. If you don't buy the Embark, it's going to be excluded from reinsurance, which could blow the plan up pretty quick. The problem with like a hemophilia or some of these is it tends to be genetic. So if you have one, you might have 4 if they're covering, a couple of kids. So, all of a sudden you could have $5 million in plan expenses out of nowhere. So that's what we're looking to protect against with that. But overall, as we started with, you guys went to the bottom number, that comes out to a 5.3% increase.
Embark benefits based on current membership at 2,482. We have that many, or we have.
So that's going to be members, so that's going to be everyone involved,
Okay,
not just employees.
okay, gotcha.
Yeah, so they do that one on a member basis. So overall, the projection comes out to 5.3%. We do want to look at May claims before our last committee meeting to see if it makes any drastic change. I don't expect we'll be higher than the 5.3% because we've really accounted for everything. So, if there's some major shift and claims drop a lot, we might be in a position where we could look at a lower scenario. But for the point of discussion today, we wanted to put this in front of you guys so you knew kind of what we're looking at, what we're expecting. and, you know, kind of go from there. Obviously, last year we had a 0. The year before, I think, was around 5, if I remember right. So if you kind of think about it in a 2-year sense, you know, it's almost kind of like 2.5, and in some regards, if you divide that out over the 2 years. So still compared to the market around you and what people are seeing, you know, even at the 5 is really, really positive.
Historically, our plan has bucked the trend. We've always gone a lot lower than this for our actual increases in our plan, haven't we?
Yeah, I mean, since you guys went self-funded in 2000, I think it was 13, 14. We went self-funded. Remember the first, early on in that time period, we had those hepatitis C drugs, Sovaldi, and Herclone, which were ultimately cures for hepatitis C for most of the population that came out. The city had about 20, you know, people that added 2 million, and I think that year, you know, it was like a 6 to 7% increase. But since that year, the increases have been, you know, I think that's the highest one that we've had really since going self-funded. So,
We've actually done a lot better.
yeah, I think everything you've done with clinic, everything you've done with wellness, you're starting to see it. It doesn't change quick, but you're seeing a lot of the benefits of that over the long term. And that's why, you know, with the team, we're looking at what's next on the wellness side, because we want to make sure that we're keeping it fresh and we're keeping people engaged, you know, in that regard. So on the subsequent page is just the, so you guys have an idea, talking with your membership, is the breakout of what that is by the different tiers of coverage. So for family coverage, it's about almost just shy of $18 a pay.
That's the biggest thing I hear is for the family coverage increases. Everyone's got a family coverage increase, or family coverage. Our department's always screams, how come our premiums keep going up? Which then it's hard to explain.
Just tell them what didn't go up last year.
That is because the projection was to go up slightly last year, and the city decided that they would handle this cost, if I remember correctly.
Yeah, I mean, the projection last year was very minimal.
2%, I think it was something like that last year.
Or even a little bit less than that, I think, yeah.
Yeah, it was, with everything going on, you know, last year, everybody kind of struggled with, hey, how do we, you know, do we want to roll out an increase during a pandemic? You know, plus just, you know, I think what Jay maybe knows better than me, but I think what also has changed a little bit is last year when the pandemic hit, I think everybody kind of the unknown on what financials would look like. I think everybody was in panic mode last year come April, May. And I don't know, Jay, if it's, I mean, now it seems like everybody at least has a better grasp on the impact financially of the pandemic. You know, whether it's good, bad, or indifferent, at least it's out of the unknown status. Is that a fair statement?
Yeah, and it definitely did have an impact on us, so yeah, feared for sure.
And I remember last year everybody saying, oh, the real estate market's going to collapse because of the pandemic and property values are going to be way down. So we won't listen to those people in the future.
It's going to take a couple years for these projections to really fall in line after COVID. I mean, as far as back to our normal trends.
Well, I don't know how much money you guys get on different tourism taxes, but driving over to the beach, it doesn't seem like.
Oh, no.
It's rebounded.
It doesn't seem like there's much effect.
They're over 90% filled for all the hotels on the beach. capacity. The median rooms, I think, are $500 a night or something like that right now. So the beaches are, trust me, I'm driven on those beaches.
Is there any real area that has been negatively impacted?
I think virtually everything's bounced back pretty well. But I'm sure there's some industries still that are struggling, and small
Yeah.
businesses that
I just
failed
didn't know,
along the
like,
way,
for-
but
For your guys' revenue sources,
Yeah.
you know, everybody was worried last year about state revenue sharing
Yeah.
and all that.
no, it's all rebounded.
Yeah, it's definitely, I think we're in a better position than we all thought we would be a year.
Yeah.
So that's definitely good. And, you know, one thing, it is interesting, we have some groups that have said, you know, Stephen, to your point, I mean, you know, anybody might not like this, but, you know, we do have some groups that have started to say, should we, with our self-funded plan, set a floor regardless of what the projection comes out at? You know, and do something like a 2.5%, even if it comes out at 0. You know, and they've been playing with that idea. Nobody's necessarily put that into any sort of policy yet, but some groups have said, hey, should we do 2.5% every year? In case we have a couple of years where it comes out at 0 and then it's 10 in the third year,
Smooth out
that
that
would
volatility.
soften that
Yeah.
impact to the employees. You know, so that's something maybe in the future that,
That is one of the challenges, because if you subsidize employees in good years, you're gonna have the rate shock the following year when it has to go back and potentially catch up.
Exactly.
Plus, so having something more moderate throughout, so that you're not having the peaks and valleys of
Yeah.
bouncing up and down based on a good
Yeah.
year or a bad year. Does make some sense.
So for the reserve, I know there's a specific amount that we have to keep in reserve. Do we have that specific number? Like last year we had 2.2. but
it's a moving target. It's ultimately, the way the state says it is, it's 60 days worth of claims. And then there's also, there's kind of not a hidden component, but when they do the financials, the actuary also does an estimate for what they call incurred but not reported. So they're guessing how many claims are out there where Sean went to the doctor yesterday, but that doctor is not going to submit it for 2 weeks, right? So they make an estimate on this incurred but not reported number, which we actually give Jay and his team every year, because you guys have to book that as a liability in the financials. So there's that number, and then there's 60 days to 2 months worth of claims.
Similar to an escrow account.
Yeah, some way. So the state minimum, what they look for is, you know, ballpark, you could take that 6.2 million divided by 4 and multiply that times, you know, 2, and that would be a ballpark of where they would do it. I mean, you would generally, they're gonna look at the snapshot at the end of the plan year. But, you know, if you want just a rough way.
Approximately $3.5 million.
Yeah.
For the 60 days, 2 months worth. We had 2.2, so we're still minus 2.2.
Well,
that
that
was
was
the
just the 1 year.
last
Yeah, for the 1 year.
We'd have to go back and get the cumulative for all the previous years to come up with the current balance.
It'd be good to know how much we still have in reserve completely on there, because if we have a lot in reserve here, does that help to offset some of these costs? Are those reserves that we already have in reserve factored into this cost?
So ultimately, when we look at the projection, we don't build anything to build reserves up, right? We don't add any fluff to build reserves up, but we don't build any drawdown on reserves as well. So we try and look at it solely on here's what it's doing. You know, some groups will say, you know, they'll account for a certain, say, oh, you know, we feel we have too much in reserves, and they'll account for that. That you can get in trouble pretty quick kind of doing that. What obviously we're trying to balance is making sure, because employees do contribute a portion, that we're not overcharging.
Right.
You know, in that regard.
Like I said, we'd like to know kind of how much we have total in reserve on these accounts. I mean, if we have 5 million, 6 million in reserves over this cumulative amount, that should help us offset some of these costs. If our projection is 6-day projection, say 3.5 million, that should be able to help reduce some of these costs from employees if we have that much reserves. So I'd like to, from our standpoint, I'd like to know how much we have in reserves in our medical.
So that.
Where is that money going?
Maybe
If it's
Jay
still
and I
sitting in
can-
reserve.
Maybe Jay and I can
You-
take that.
You've had that
offline
on
and see
previous,
what we can-
you've shown us the history previously, year by year.
Yeah.
Just need to take a look at that. See
Yes,
what that,
if we can do that, if we have plenty of money in reserves, maybe that can help offset some of these costs, because that money's got to do something, just sitting in reserves over there. If it's over and above our 6-day projection. So if we find that out, that would be good to know.
Definitely, I can work with Jay and his team and get some of that. Because we have it on the spreadsheets, but I also like to balance out with what your guys' numbers are. So I was like, oh, you got all this money.
Yeah.
We'll probably be able to have that by the July meeting, right?
definitely, yeah.
Any other questions or comments?
Well, I have two, actually. I'm playing catch up. Sorry for being late, first and foremost. First question, did COVID, and you may have went over this, did COVID have any effect on my claim?
So yeah, kind of what we talked about was if you look at, page 2 of the claims and you look at last year in April and May, in those months, you obviously had claims were down in those months because people weren't going to the doctor. Right, so if you look and you see, even if you just go to the FAR total where you see the 615 and the 597 claims per employee per month, claims were lower during those months because a lot of things were shut down, right? And then, so the other part of that, I think we gave that out in the last meeting, was kind of that COVID summary, which was how many claims, what was the actual cost of COVID itself on the medical plan? And I'll see if I have that on my iPad.
Yeah, we did have that, because I know I gave those numbers out to the set. And we did have 2, I think, claims that hit the $100,000 mark that were COVID related or COVID complications. So, you kind of have it on both ends in terms of people weren't going to the doctor. However, we had some that,
ICU and stuff like that.
that ended up costing the plan on that side, so.
Second part of it, did it affect the pharmaceutical industry?
So that's a great question. Here's what we saw in pharmacy overall. Overall in pharmacy, the impact was negligible in the sense that most people still filled their prescriptions. What everyone will tell you probably did happen a little bit is, think about, I felt a little sick, maybe I got a sinus infection, and normally I would have gotten an antibiotic for that, but maybe I just said I'm gonna ride it out because I don't wanna go to an urgent care where a bunch of people might be getting tested for COVID, things like that. So there's probably a little bit of a drop because of people didn't go get some of that care. Maybe the doctor would have prescribed them something. But overall, for the most part, people filled their prescriptions throughout the pandemic. You may remember, it's hard to believe this was so long ago, there was a little bit of fear at first about a drug shortage, like whether or not, so everybody, Cigna and all the companies removed like some of the limits so you could go fill them quick. So what we did see is like April, May, June, we saw more fills than normal. But then obviously because you had gotten a 3-month supply or 6-month supply or whatever, now you didn't fill that for the next 6 months. So it all kind of washed out in that time period, but that was a little bit what we saw in that regard. So overall, I would say no, it really didn't affect pharmacy. I found that page, so you guys had 561,000 in overall spend last calendar year because of COVID. So an extra $500,000, but that $500,000 was probably negated by all the people that didn't go get care. But ultimately, yeah, there's probably about $500,000 in there, a little bit extra because of COVID. And you had, just to give you an idea, you had 11 hospital admissions because of COVID for 79 total days in the hospital. And
that was as of that time, and
That was-
and that was a
that
couple
was
months
just
ago.
calendar year last
Yeah,
year,
so, and we had more.
early this year. Yeah, so the average length of stay was about 7 days, and there were 15 of those 79 were actually ICU bed days. So you did have some.
Like I said, again, we had, there was 2 that had significant time in ICU this year, so that's not included in those numbers.
Along those same lines, have we seen any increase or decrease in telehealth usage because of COVID, or maybe a decrease because more of the primary care doctors have went to telehealth? Is there any changes in our usage on that?
So you had 301 telehealth visits last calendar year. Let me see if I can find the page.
More and more
So,
doctors.
well,
now are
here's
doing
what's,
telehealth.
so hold on, let me expand on that. Steve, you had 301 MD Live or Amwell, which is the Cigna one. You had 737 people actually see their own providers through some sort of telemedicine. And that, I don't have a number of the year before, but, oh, actually, yes, I do. That was compared to 9 the year before.
So huge, hundreds, yeah,
9 the year before. So you actually had,
80 times increase.
so you had 737 medical and 985 behavioral. So combined, you had about almost 1,700
Are we seeing
versus 9 the year
Are we
before.
seeing any trend in that this year so far? Are we seeing a decrease or increase?
Haven't looked at that yet this year to see. But I think what's changed because of COVID is, and it happened to me, right? My doctor let me do virtual visits. You know, one of my wife's doctors let her do virtual just to fill a script.
Yeah.
You know, and you know, so candidly, it's kind of a racket that you got to go for an appointment just to fill a script anyway.
Yeah.
But I'm not a doctor, but you know, think about it, saved her 2 hours of driving, probably 45 minutes of sitting in the waiting room, and then to have 5 minutes with the doctor. So hopefully doctors now are embracing, saying, hey, wait a minute, I can still get paid, and you know, they'll start to
See,
do
I'm
that.
wondering about that one where an employee may have normally used, if it's just something simple, the telehealth, but they call their doctor's office, oh, the doctor can see you on a teleconference call in 2 hours. So
Yeah.
now they end up paying their $20 or just $40 over here as opposed to having free over here.
Yeah. But you know what? It's definitely, if it's something more than like a sinus infection or something, I'd rather, me personally, I think it's better they call their own doctor.
Most
Because it
yes.
gets logged in the EMR, they're able to see those trends. So, yeah.
I'm just curious how that was trending in there.
Yep.
I think that's going to continue on the telehealth because a lot of places, including the doctors, seem to be going more towards Zoom meetings.
You also had, you had a 42% jump in urgent care utilization, which is probably a combination of some people stayed out of the ER. So maybe there's some good lessons learned. And then part of that, there's probably some where they were going there for testing. So that's probably some of that spike.
I know just based on some of the patients that I've had, some of them have expressed that they would rather go to an urgent care than an ER because of the increased chance of COVID in an emergency room as opposed to the urgent care.
And then we've also heard the bad stories about somebody that should have gone, but didn't because they didn't want to get COVID. So,
Yep.
you know, there's both sides of that. So does that answer?
One more question. A couple of years ago, I say, we discussed expanding the provisions that the clinic would provide.
In which regard, was it more like, I'm trying to remember the
Testing,
discussion.
in-house testing, procedures kept in-house. We were talking about that before, so some time ago, we moved forward with it.
In terms of expanding services at the clinic?
Yes,
So we, that was before COVID that we were talking about that, and the only thing that we really expanded is in terms of doing pre-employment physicals at the clinic for administrative positions. We've started doing that to just also introduce employees, to the clinic. But in terms of expanding services, that's not something that has been done yet. Like I said, a lot of that got kind of derailed because of COVID, but it's certainly something that we continue to talk about. Things are so different now because of COVID. One of the things that I know we've been reaching out to the clinic in terms of just, not a barrier, but a challenge is in terms of getting a provider that will commit to coming in, you know what I mean, on a, weekly basis, whatever, without that kind of guarantee. And so how do we build that into the, in terms of what they're paid and whatnot. So not that it's not something that we're not continuing to look at, but also I know that some of the things that Tony's been exploring is that Dr. Tarancinko is, I don't know if certified is the right word to use, and that, but in several different disciplines. And so just trying to expand on making sure that employees understand what all she is capable of doing outside just being a general practitioner.
okay.
So trying to take advantage more of that. But, and you missed it, we're talking about adding programs, not necessarily to the clinic. But just, overall, again, with the shift in terms of how employees are, not just employees, but how people are kind of seeing their doctors has changed so much as COVID that there's just a little bit of a delay in terms of what else we can do to expand things out there.
It's funny you mentioned it that way, because that's why I asked the question, because the success you're having with the programs that you've been having.
Mm-hmm.
And I remember back when we were talking about this a couple of years ago, the possibility of cost savings it would have to expand within clinic internally.
Yeah, like I said, it's certainly something that we're going to continue to explore. In the meantime, what we're doing is just trying to drive more employees to the clinic to use the services that are offered, because there's still a lot of capacity there, and there's a lot of employees that don't use it, don't know about it, don't, whatever. And so just really trying to increase the awareness. That's why, like I said, we did the pre-employment physical, so then they can see the location, they can meet the doctors. COVID was very, if there's a good thing that came out of COVID is a lot of our employees got to go to the clinic because they, it was a convenient service that we offered for them. And the clinic was a good partner through that for us. And so we've had a lot of exposure at the clinic that we're hoping will turn into patients, because again, the more claims that we can send to the clinic, the better off for the plan. So whereas we've had a pause on adding new services, we really tried hard to increase both marketing and just ways to entice employees to get them to go to the clinic to take advantage of the service that we have. So there's plenty of capacity there. And we're going to increase capacity by potentially adding another provider out there. Same services, it wouldn't be new services, but another provider that'll open up room. So to be able to see more people.
It seems to be working, your plan seems to be working.
So yeah, but we're going to want to continue to try and get more employees to to go to the clinic. And
Yeah, and the one thing I'll tell you, this kind of discussion comes up all the time, like, adding specialties to the clinic. And what I would say is always interesting when it's, kind of family practice, general practice, kind of serve everybody, right? But now if you start talking about, let's say you want to bring a cardiologist in 2 days a week, one, there's sometimes equipment needs that can get pretty expensive, you got to add some stuff, but, you'll have a certain percentage of people that are already working with a cardiologist, right? They know they have someone, and they're not going to leave their doctor, right? Even if it's free, like, nope, that doctor's kept me alive, I'm not leaving them, right? And you get into more of these, it's kind of like dentists, right? Like people, it amazes me that people go see all kinds of different, general practitioners and medical, but man, don't mess with their dentist. In network, out of network, like they're going to their dentist, right? And I think a lot of the specialties where the challenge comes is you've got a smaller percentage of the population that you can target, and they're just people are tied to their doctor, or maybe they're going to be more skeptical, like, specialists, they're expecting them to be in the fancy building and like, right, it's, you know, so there's different expectations with some of those, so that's the challenge we always kind of battle with bringing someone in to look at that.
I went back a number of years ago when we went to the lower cost insurance, lower cost Cigna, the Affordable Care Act Cigna, and we had all those issues with loss of doctors where there's only like 2 allergists in the whole county, and we had to fight to get the second one in the North County.
Yeah,
So yeah, that was
one we ended.
yeah, people were irate that they lost their doctors.
Oh, yeah.
Yeah.
So
Yeah, and it's funny how that happens with specialists, but not primary care. And we have such primary care shortage right now that's why the clinic's such a great benefit. Because a lot of people, it's like, oh yeah, we can see you in a month in the primary care doctor's office.
Yeah, and even Cigna is doing some promotions to get people to the clinic. And again, we put all that stuff in our weekly wellness email. This month is Men's Health Month, and so they're, you know, really pushing, and they do giveaways and whatnot to try and get employees, you know, to go to the clinic. So like I said, that's kind of what our focus has been on, is really just trying to increase the utilization pool we have, while still exploring other opportunities.
a lot of our guys and gals go to the clinic. Do we still have a Cigna rep that comes once a month?
No, but
We utilize, I send them to you too. If
That's
we have an
perfect.
issue.
That's perfect. That's
And
the
you
way
have,
it
you
should
have
be.
someone you work with, correct?
yeah, we do. We have a claims call every other week. So that, you know, we, you know, have constant communication in terms of with Gearing Group and Cigna to have conversations about if there's claims issues. So that seems to have been better utilized than what that
Right.
rep
I
was.
knew we didn't have one full time, obviously. I just didn't know, because for a while we were having one come once a month.
You
Yeah,
can't
but
really-
that's stopped in
Yeah.
COVID too.
Okay, well,
But she's
that
on,
makes sense.
she's on
Makes
the
sense.
calls, so
Okay.
anything, you know, we don't wait for those bi-weekly calls either. I mean, clearly if something comes up, it's immediately addressed.
I know.
So,
You've
yeah.
been really good at getting those things.
And a lot of the
Thank you.
challenges now that we run into is, it's something on the doctor's end. It's not normally like a Cigna problem. It's normally somebody needs to pick up the phone and call the doctor and say, hey, you billed this wrong, or you did that.
Usually a bad CPPT number.
So that's what like my team kind of does with Joe's team, is normally they're calling the doctor and stuff, so that, you know, having a signal rep, they can really only fix the issue if it's on the Cigna end. So that was part of why we said, wait, this doesn't really make that much sense. I have that. So in July, we'll have the dental renewals, and we'll look at updated claims. We'll also talk a little bit about Motivate Me and any potential adjustments or tweaks we want to make to that. And we'll try and bring some information on the Omada program, since that will hopefully be something that we'll be rolling out. And then I'll get with Jay on the reserves.
I'd like to see that second phase of coming in after the Amado with the type 2 diabetes cares and stuff like that. I think that would be a good program.
Yeah, and I know.
Because I think there's a lot of employees that have that.
Oh, yeah.
And
And what we
I,
know are.
and I know Cigna, so Amada developed those after kind of the initial program. So I know I think they're working on a way to integrate that into, you know, can they add that into claims? The one problem with it, not problem, but the diabetes prevention program is easy because it's preventative. So just run it through the claims, make it free to the employees. When you start getting into like the type 2 program, now you're into a situation of, it's not really a preventative program, it's more of a care program. So there's different rules that come into play with what you can do. So that's definitely something that develops. They also bought a company, I think I told Jennifer about this one day, but they bought a company called Physera. And Physera is a virtual physical therapy company. So I think at some point down the road, you may see that sort of integrate. I actually tried it. I had kind of like a hamstring strain and tried this virtual program, and it was really unbelievable. Do it at home, on your schedule, talk with a coach, they build a program, send you any of the equipment you need, and They build like all your, anybody that's gone through rehab, they build all the exercises into the app every week. So you just pull up the app, they tell you how many times, you do it at your convenience, it walks you through the little 3D model, walks you through every exercise. So I think when you look at you guys working shift work, right? If you're, a physical therapist wants you to come in on Wednesday, but that's the day your shift is, well, you can't get in, so looking at ways to expand access, not saying you would get rid of regular physical therapy, but here's another type option. And again, any of those programs, as long as they set up a fee structure where it's only if it's used, it's not a big deal for the city to add it because you're already paying for it, right? You're paying for, if Sean moves from in-person physical therapy to virtual, there's a savings anyway.
Right.
But we don't have to sit there and say, okay, well, this is gonna cost the city $200,000 more to add it. Can we afford to do it? Because it's just replacing something that we're already paying for. So those programs have a lot more appeal than, everybody that calls us and wants $100,000 to put a new program in that nobody would use. So.
Yeah, type 2 motivate me with the exercise and the dietitian. Those are the two big, well, and the weight loss as well, but those three are the big things for type 2s.
Well, now that we've worked out the kinks in terms of, FD and PD's physicals, we're
Yes.
expecting big things from you guys on Motivate Me.
I know a few people already that now that they know about it, already taken advantage and gotten gift cards.
Good.
So,
That's really good.
yes, it is.
All right, any other questions or comments or anything else we need to discuss? So the next meeting will be a big meeting. We will need a quorum so that we can make some decisions. So hopefully we can get that. We'll probably do it the same way, that we'll have options like this. So that it's slightly more convenient to be able to have a quorum. So, all right, no other questions. We will end the meeting. Thank you all very much. Good to see everybody.